All right, let's dive into a crucial topic for plastic surgery boards: hand and finger amputations.
Absolutely. Essential knowledge for exams like the FRCS plastic surgery.
We're going to break down the key principles to help you prep.
Sounds good.
So starting with the basics, trauma. That's the most common reason for emergency amputations, right?
Yeah, definitely. And when we talk about trauma, crush, and avulsion injuries, those are the main culprits.
Got it. And then there's elective amputations. Those are planned, right?
Yeah.
What kind of situations call for that?
Right. Elective amputations are for specific situations, like when you have malignancy, osteomyelitis, vasculitis, gangrene, basically when the tissue is beyond saving and it could even be a risk to the whole body.
Makes sense. So when we're dealing with trauma, how do we decide between amputation versus trying to replant or salvage?
Well, sometimes the damage is too severe for replantation or salvage to be successful.
Okay.
Amputation's also the go-to when we're dealing with patients who have severe vascular disease, or if they have other health problems that make them high risk.
Right. It's got to be a quicker, more definitive solution in those cases.
Exactly. And let's not forget, for some patients, especially if their work involves their hands a lot, amputation might mean getting back to their lives faster.
That's a really good point. So let's say we're in the ER. A patient comes in with a traumatic amputation. What are the absolute must-knows in that initial assessment?
First off, you need to figure out the level of the amputation.
Okay, and what else?
Is it complete or is it incomplete? What caused the injury? Which structures are involved? Are there any other injuries to the hand along with the amputation? And then we've got to consider things like hand dominance, what they do for work and for fun. Did they have any problems with their hand before the injury? What are their expectations?
Got it. So getting a full picture of their situation, really.
Exactly.
What about imaging? What do we need to see?
At least 3 plain radiographic views of the hand. If we need to, we'll get specific views of the fingers. And if there's any suspicion of wrist involvement, we'll get wrist studies.
All right, so what are the main goals when we're performing an amputation?
The big one is preserving length as much as possible. That's especially true for the thumb. We also want to make sure we have durable coverage with soft tissue. We want to try to preserve sensation and prevent those painful neuromas and joint contractures. Minimize the impact on the patient's life, and make sure we can fit them for a prosthesis early on.
Right, to help them get back to their life as quickly as possible.
Precisely.
Now, you mentioned some situations where elective amputation is indicated. Can you give us the full list?
Sure. So definitely when the injury is too severe to salvage. If the patient's not a good candidate for replantation, or if there's a high chance the replant would fail, like if they have vascular disease or are a smoker, if there are injuries at multiple levels, if anesthesia is too risky, or if the patient just preferred amputation, which can be the case for manual laborers.
Okay, so lots of factors to consider there.
Absolutely. Also, things like tumors, infections like osteomyelitis or necrotizing fasciitis, severe burn contractures, vasculitis, ischemia, necrosis.
Got it. So are there any times when we absolutely shouldn't do an amputation?
There aren't really any absolute contraindications. However, if the patient is a good candidate and we have well-preserved amputated parts, replantation should always be on the table.
Okay, good to know. So let's talk about the actual surgery. What are the general surgical principles for amputation?
Okay, so first things first, we got to make sure we have adequate anesthesia.
Of course.
We give antibiotics before the surgery and make sure they're up to date on their tetanus shot. We clean up any obvious contamination and irrigate thoroughly with saline. And of course, we do all of this with a tourniquet in place.
Makes sense.
We debride any tissue that's not viable to prevent infection. We assess the soft tissue coverage and shorten the bone if needed so we can close everything up nicely without tension. Ideally, we want to use volar skin for that distal stump coverage, or we might do a fish mouth incision.
Okay, what about the tendons?
For the flexor and extensor tendons, we cut them back and we absolutely never suture the ends to the stump or to each other. That can cause something called the quadriga effect, which we definitely want to avoid.
Got it.
For the nerves, we identify them and transect them proximally to where we're amputating. That's key to preventing neuromas.
Okay, and then closing.
For closure, we use interrupted, non-absorbable sutures, loosely approximated. We don't want to close too tightly and risk cutting off blood flow. The goal is a nice rounded contour, so we'll trim any dog ears.
All right, so after the surgery, what's the post-op care like?
We splint the hand and start range of motion exercises pretty early, within 3 to 5 days. Oh, and one more thing. For those digital amputations, sometimes we can actually manage them right in the ER. Just use a digital block and a finger tourniquet.
That's pretty efficient. So what kind of outcomes can we expect after a digital amputation?
There are cases where a primary digital amputation actually leads to better function and a quicker return to work compared to a complex reconstruction or replant. And by transecting the nerves proximally, we can really minimize the risk of those painful neuromas. Plus, getting people back to work early is also linked to fewer neuromas.
That's good to know. Are there any common complications?
You might see some cold intolerance and dysesthesia, but they usually go away on their own. Sometimes it can take a while, though, even up to 2 years.
Right. Now let's get into some specific types of amputations. Let's talk about amputations through the DIP or PIP joint.
Okay, so for those, we'll shorten the bone and close it up primarily. We contour the stump using a rongeur and remove the articular cartilage to prevent a pseudobursa from forming.
Okay, makes sense.
And we also need to watch out for something called the lumbrical plus deformity. It's where the FDP tendon retracts and causes the PIP joint to extend when the patient tries to flex their finger.
Oh, that sounds tricky.
Yeah, but we can fix it by cutting the lumbrical tendon.
Got it. What about amputations through the middle or proximal phalanx?
For those, we do skeletal shortening and primary closure using dorsal and volar skin flaps, kind of like a fish mouth.
Okay. And when the amputation is proximal to the proximal phalanx, what do we need to keep in mind?
Well, you can usually get up to 45 degrees of flexion from the intrinsic muscles, unless the amputation is really close to the MP joint. If the proximal phalanx is very short, it might make more sense to do a ray amputation instead.
Okay, I see.
And another thing, we have to be careful not to tether the flexor tendons, or we could end up with that quadriga effect again.
Right. Any other tips for this type of amputation?
Oh yeah, if the FDS tendon is injured proximal to the middle phalanx, we don't need to worry about preserving length for PIP motion.
Makes sense. What about thumb amputations? Those seem like they'd be especially challenging.
Absolutely. Restoring sensation is crucial with thumb amputations. If there's no bone exposed, we can let it heal by secondary intention. But if bone is exposed, we'll need to cover it with a flap, ideally a cross-finger flap or a radially innervated sensory flap.
Got it. And for multiple digit amputations?
Our main goal there is to preserve as much viable tissue as possible. You never know if they might need reconstruction down the road.
Okay, that's a good point. Now let's talk about ray amputations of the hand. When are those indicated?
So ray amputation is the way to go if we're amputating at or near the MP joint. We usually do a subtotal metacarpal resection.
Okay. And how does that impact function?
It's going to weaken their grip strength, their key pinch, and their supination strength. But we always got to weigh that against the problems they'd have with a gap between their fingers. Things could fall through the gap. That's especially true if the long or ring finger is gone.
Right. I can see how that would be a problem.
Yeah. And one more thing about ray amputations, they're rarely done in the initial trauma setting. It's usually an elective procedure.
Interesting. So how do we do a ray amputation?
We make an incision on the back of the hand, over the metacarpal, divide the extensor tendon, dissect off the periosteum, and then do the osteotomy at the base of the metacarpal.
Okay, and what about the different metacarpals?
For the third metacarpal, the index finger, we can either transpose the metacarpal or suture the inner metacarpal ligament. The fourth is similar. But for the fifth metacarpal, we got to preserve the base because that's where the FCU and ECU muscles attach.
Right, important for function.
Exactly. Same goes for the second metacarpal. We preserve the base to protect the ECRL and FCR insertions.
Got it.
Then we distract and cut the flexor tendons, cut the neurovascular bundles, trim up the skin flaps, and close them.
So what's the typical outcome after a ray amputation?
They'll lose about 15–20% of their grip strength, and their palm will be a bit narrower.
Okay.
If it's the index finger that's amputated, they'll also lose about half their pronation strength. Sometimes we can do a border ray translocation to improve the appearance of the hand.
Interesting. Now let's move on to wrist-level amputations. What are the main considerations there?
When it comes to amputations through the carpus, the functional outcomes aren't as good as with more distal amputations. Our focus is on saving as much tissue as we can. If possible, we want to preserve the radiocarpal joint. That'll make it easier to fit them with a prosthesis.
Right.
Now, wrist disarticulation. It's actually a better option than a long below-elbow amputation. It lets us keep the DRU joint and the radial styloid intact.
And what are the benefits of that?
Well, it allows for full supination and pronation, and the prosthesis will fit better.
That's great. So how do we go about a wrist disarticulation?
We ligate the radial and ulnar arteries and transect the nerves as high up as we can. Then we pull the tendons up and cut them proximally, letting them retract back into the arm.
Okay.
We close the incision using a fish mouth technique with a longer flap on the volar side and a shorter one on the dorsal side.
Got it. And finally, let's talk about forearm amputations.
With forearm amputations, we cut through the radius and ulna at the same level. We use muscle flaps to pad the ends of the bones.
Makes sense.
We want to keep as much length as possible, but for a useful prosthesis, they'll need at least 8 to 10 centimeters of the radius and ulna remaining.
Okay, that's good to know. Anything else to keep in mind for forearm amputations?
If there's a chance they might need a hand transplant in the future, we want to make sure we don't shorten the tendons or the neurovascular structures too much. And we bury the nerve ends deep in the muscle.
Okay, I see. So to wrap things up, what are the absolute key takeaways for the board exams?
All right, remember your ABCs in trauma cases. Always assess for the possibility of replantation.
Of course.
To prevent neuromas, cut back the nerves and bury them away from the incision site.
Got it.
When you're dealing with a digital amputation, don't suture the tendons to the stump or to each other. And as a general rule, preserve as much length as you possibly can.
Great advice. Well, that concludes our deep dive on hand and finger amputations. Hopefully everyone feels more prepared for their board exams.
Definitely. Knowing the indications, the contraindications, the surgical principles, and the specific techniques for each type of amputation is key to taking good care of your patients and doing well on your exams.
Absolutely. Keep studying and good luck.
Good luck.